Thank you for having me, first of all, to your lab, and also allowing me to come through to your offices. They're absolutely beautiful, and I can't believe you're right next door to the Mall of Africa. So my sister was out here, she's flying to London from Australia, and she went shopping at the Mall of Africa, and we definitely better standards, she feels, than Sydney shopping centres, so that's good. But what I'm going to be discussing today is really, and please stop me if you would like to ask questions in that, it's sort of a very informal presentation, but Am has just asked me to just really discuss a little bit around bipolar disorder, and in particular where, as a psychiatrist, one would actually be using or where does Tegretol CR fit in terms of the management of bipolar. And then I'm going to do a little bit on ADHD, looking a little bit, just touching a little bit on features of adult ADHD. As Amber's mentioned, that's sort of I do quite a lot of adolescent work. But I'm quite involved with the special interest group for adult ADHD, and it's actually a very exciting field to get into, and there's a lot of advances, and where we're going to be discussing the stimulants and looking in particular where the various medications may fit in. But as I say, if it's getting boring, please, I'll see by your faces. If it's getting too long, please shout and I'll skip through some slides. And then if there's time over, I was just trying to think how to do this in terms of looking at two case presentations, which forgive me, I haven't had time to actually prepare, but they're sort of just going through from a clinical perspective of two patients where we do sometimes, or quite often, struggle with the differential diagnosis of what is bipolar, what is adult ADHD, or what is perhaps a comorbid condition, which is often the point. Okay. Right. Okay. Just quickly, some of the objectives, but obviously, if I'm going too slowly, we'll go through quicker. But just to understand what bipolar disorder is, what are some of the clinical features, the bipolar subtypes, and also what is the course and lifetime progression of bipolar disorder. And then very importantly, now we all getting used to, I trained with the DSM-4, then the DSM-4 revised version, and now from 2013, thank you. From 2013, we're now working from the DSM-5, and so I'm having to sort of needing to get used to some of the new criteria. I was doing medical student exams last week, and actually they taught me a lot about the DSM-5. I've been trained on DSM-4, as I'm sure most of you have as well, maybe getting used to now the DSM-5. But I must say, from the perspective of bipolar and understanding bipolar disorder, and perhaps depression with agitated features, the DSM-5 is actually a really helpful classification to use. And then just in terms of looking at comorbidities, Amber just asked me to sort of include how would you differentiate clinically between a bipolar mood disorder or bipolar disorder versus hyperactive, impulsive, inattentive ADHD. And then just in terms of looking at some of the treatment guidelines or treatment summaries, and just seeing where, as a clinician who's guided by these guidelines, Tegretol or carbamazepine would fit in. Okay, and then looking specifically as a clinician, where would we use, so in what circumstances or situations would I be more likely to prescribe Tegretol and sometimes off-label Trileptal. Okay, so if we look at bipolar disorder, we know that it's a very complex disorder. And it's cyclical, and what makes it very complex is that it's a cyclical disorder and it occurs in episodes. And these episodes range from very abnormally elevated moods, but these moods don't always have to be elevated and euphoric and happy. They're often quite irritable and agitated to a very severe depressed mood. And what we see in terms of bipolar disorder is the cyclical nature of the disorder, as well as the episodes of these moods, for individuals can vary. So some can have sort of very few episodes over a lifetime. Some can have within a month multiple episodes of ups and downs. And so it's a very cyclical mood, disorder. This is where we're looking at the new DSM classification with the DSM-5. Sorry, my knife is And what's very, very helpful with the DSM-5 is it actually allows us to be perhaps a little bit more clearer where our patients fit as far as the sort of the cyclical nature of the mood, but not only that, as what is the poles of the mood. So some patients present with pure depressive episodes, then they present with manic or hypermanic episodes, and some present with what we call mixed episodes. And when we look at the DSM-4, they were very, very clear that you either looking at patients who only have depression as unipolar, or you're looking at patients with bipolar who are classified as bipolar because they've had at least one or more hypermanic or manic episodes, and then they've also had depressive episodes. But that's not a criteria for bipolar. You don't have to have, according to the DSM, depressive episodes. As long as if you've had one hypermanic or manic episode, barring not drug-induced or medication use, you are bipolar. According to the ICD-10, that's not true. The ICD-10 would class it as a single episode. If you've had one hypermanic or one manic episode only, you're not yet bipolar. You need to have two or more mood episodes, with one of them being hypermanic or manic. So when I was training, and up until recently, the DSM-4, when we looked at mixed episodes, our patients needed to have together meet the criteria for a full depressive episode and a full manic episode. And that could happen that they could be experiencing all those symptoms at the same time within a day, or that mood could be cycling. So in the morning, they're very manic or hypermanic. In the evening, they're very depressed. But what we actually did as clinicians was we kind of moved out of that box, because patients didn't read kind of textbooks, and mood disorders don't follow specific clarity in terms of mixed episodes. So we were finding, and this is why they've looked at the differential, and they've changed the classification to be more dimensional, because we were actually sort of being a lot softer in terms of how we defined a mixed episode. So we were defining someone who was manic but also had some depressive features as being mixed. But we were in actual fact, according to DSM-4, wrong. And what they found is that in actual fact, that's the more typical presentation of your patient who, with bipolar, has mixed features. And so in the DSM-5, we've still got the typical bipolar presentation of mania, hypermania on the one side, and depression on the other. But we now get mixed features. And I'll show you another diagram just now. But what we see is that you've got a manic episode with mixed features. In other words, you've got a full manic episode with some features of a depressive episode. So it doesn't have to fulfill all the criteria of depression. And on the other side, you've got the same thing. Full depressive episode with some features of mania. So it's a depressive with mixed features. That does, for clinical, make it a little bit difficult, because depression with mixed features, if there's no hypermania or mania or history of that, that actually falls under the unipolar depression. However, our management of that is very often, the medications we use is very much how we would treat our bipolar patients. But this is actually much more user-friendly. It's actually more applicable to actually how we see our patients in clinical practice. And then just to sort of look at the DSM-5 classification of mania. So just to go through some of those symptoms that we look at in terms of defining what a manic episode is, it needs to be a distinct period of abnormality and persistently elevated, expansive, or irritable mood. And that's what people forget, is we often think mania, hypomania, it must be happy. But often people, particularly ladies, are quite irritable, they're quite agitated. And what's new for the DSM-5 is that they also have added, as part of the primary presentation, is persistently increased goal-directed activity and energy, okay? Whereas before that used to be one of the symptoms, now it is a have to be, together with the elevated mood. And in terms of a manic episode, it needs to last 1 week, be present most of the day, nearly every day, and there must be significant drop in functioning. So most manic patients usually require hospitalization, and they may or may not be psychotic. And then together with the primary criteria is you need to have 3 or more of the associated symptoms if the mood is elevated. If the mood is irritable, 4 or more symptoms. Okay, so the mnemonic dig fast, distractibility, insomnia, grandiosity, flight of ideas, activities, pressured speech, thoughtlessness, risk-taking behavior. But when you look at adult ADHD or ADHD in children in adolescence, you can see that there's actually quite a crossover. Ooh, sherbet. There's, kids, adolescents, adults that present with ADHD are quite distractible, they're energetic, they're very talkative, they're pressured, they're very risky, they're very, very impulsive. The difference being, and we'll get into that a little bit more, is that as far as the activities, and this is very specific, and that's why they mentioned it, was that in the mania, it's increased goal-directed activities. Okay, so with the ADHD presentation, it's not necessarily goal-focused. It's often this frenetic hyperactivity, darting from one thing to the next, sort of not being very, very productive in terms of the activity. Just shout if there are any questions.
So what's the difference between hypomania and mania?
Okay, so we're going to get, good question. Okay, and when we look at hypomania, the symptoms are exactly the same. However, and don't ask me why they've come up with in terms of the number of days. So for mania, you need a week or more of these symptoms, of daily presentation. For hypomania, you need 4 consecutive days, and present most of the day, nearly every day. The same symptoms of mania, the dig fast, but the difference is that the symptoms are not severe enough to cause marked impairment in social or occupational functioning. There usually is no need for hospitalization, and they should never become psychotic. So if anybody you think is hypomanic and they're suddenly psychotic, they immediately fall into the manic or the need for hospitalization. And this is where you'll never see, hardly ever see a patient coming to you who's hypomanic unless there's extreme irritability and agitation, because patients in hypomania love it. They love it. They get a lot done. They've got a lot of ideas. Families may not. And this is a big problem that we have in terms of medication, is that our patients don't like that feeling of, they love their highs. They just don't like that feeling of dull. They don't feel as creative. They don't feel as sort of extroverts or impulsive or fun or off the cuff. So with the hypomanias, it has to be 4 or more days. I don't know why, but that's certainly something that's stayed since the DSM-3 in terms of the time. The other important thing is the best people to speak to, and this also helps when we're trying to make a differential diagnosis between adult ADHD and bipolar, is to get collateral. So it is very important, and it is also a criteria for hypomania, which often can be more difficult. Mania is often, it's not difficult to miss. You know, we were often taught to sort of, if one of your patients you're interviewing and suddenly gets up and sort of puts on an act for you, or suddenly does karate chops, or a Bruce Lee impression, there's no question that person's manic. I recently, she's an elderly lady, she was in her 70s, a long-term history of bipolar, and she was admitted very manic. And I remember seeing her, and she was actually very religious and grandiose, and she believed she was a healer. And actually seeing her in my office, and Amber knows me, I'm terrible with time. I think I keep you waiting. Amber gets to do a lot of her admin. And my mother was, and my mom's my receptionist, and she was like, what on earth is going on? This is just taking, this lady's so psychotic, why am I taking so long? Meanwhile, I couldn't get out of my office because this lady is performing a sort of a healing and a cleansing ritual in my office. So the manias can be quite entertaining, but when that mania becomes very irritable and agitated, that's where we often see the dangerousness, so to speak, in terms of the danger of the person to themselves, risk to themselves, and risk to others, because they just have a very low frustration tolerance. But the hypermania, so it's really the same symptoms, but functional, okay? And family will also tell you, and that's where the collateral is very, very helpful, because a lot of our patients may not say anything because they like the hypermanias. They look forward to that, or they stop their meds to try and feel the hypermania, whereas family will come, and they often, particularly when it's quite subtle, when you sort of, you know, when you ask questions like, have you been a lot more happier? And particularly when someone's coming out of a depressive episode, a severe depressive episode, any elevation or improvement in mood can maybe seem to them as though it's like, it's sort of an extreme difference. So that's where collateral comes into play, is very, very helpful from a diagnostic perspective. And then bipolar depression, and this is the main, if patients don't come to you in their mania and dysfunction there, this is the most often the reason why patients will present who've never been diagnosed with bipolar, is because they present with a severe depressive episode. And according to the DSM-5, and the criteria for a unipolar depression and a bipolar depression are exactly the same, okay? 5 or more of the following symptoms, and again, they specify at 2 weeks or more, and there must be a previous change in functioning. One of the symptoms must be a depressed mood or loss of interest or pleasure, okay? And when there's loss of interest or pleasure, not so much a depressed mood, the number of criteria needs to increase in terms of the other associated symptoms. So the SIGI CAPS is a good mnemonic to remember. So typical of a melancholic depression, unipolar depression is very much like a bipolar depression. And so this presentation is exactly the same. So sleep is decreased, the anhedonia, the interest decreased interest in activities, guilt or worthlessness, but it's not an essential criteria. A lot of patients with bipolar or severe unipolar depression have this intense, what we call pathological guilt. They apologize for everything. They apologize for being alive. They apologize for wasting your time. They think they're the worst person in the world. They've harmed people. It's almost bordering a little bit on a almost psychotic kind of feel. Energy is decreased, concentration difficulties, appetite disturbance. Often what sometimes can be a bit confusing is you would expect in a melancholic depression that there would be this very extreme retardation, that very slowing, the person walks slowly. Their affect is blunted, their facial expressions are blunted, they talk slowly, they answer your questions slowly, it's difficult to communicate with them because it's sort of a one-word answers, or they might just shrug their shoulders. Or they might actually be quite agitated. And so that's where one's got to be careful not to say, well, this person's depressed, they're agitated, so they immediately have a mixed episode. And then very importantly, suicidal thoughts. And this is often, as with our unipolar melancholic depressed patients, this is where our bipolar patients are at the highest risk in terms of suicidality. So that this is what puts patients with bipolar high risk as far as suicide, is their depressive episodes. And this is the big problem, is that a lot of our patients, they hate feeling depressed, but they miss the hypomania, they miss the highs. But it's the depression that is so very often very dysfunctional and high risk for them. And so it's the ability to educate our patients to say, well, what we're wanting to do is try and stabilize the mood, but also importantly is to prevent further relapse or future relapse. And obviously, like with any psychiatric disorder, is the more relapses you have, the higher risk you are of relapsing. And the more difficult it becomes to treat, the more residual or remaining symptoms you have, which then puts you at higher risk of having another episode. So this is the thing, is that a lot of our patients sort of feel, well, it's just for 6 months, it's fine. Or the moment they start to feel better, they stop their meds. Okay, so bipolar depression, the same as unipolar depression. And then when we looked at mixed features, this is what we would say is mixed features using a specifier, and this would be manic, hypomanic with 3 or more symptoms of depression, and then the other is mania with, or hypomania with mixed features. Depression with mixed features, so it's full-on depressive episode, but 3 or more of the hypomanic, manic symptoms, but usually, it's cut off there, hypomanic or manic symptoms, or mania, hypomania with mixed features, which is 3 or more of the depressive symptoms. Okay, and that's actually, it's far more user-friendly, and clinically it makes so much better sense, and also helps a heck of a lot when we come to choosing our choices of medication. And then just quickly, the bipolar subtypes. Okay, so that's also quite important for us to know, because that will determine sometimes prognosis, but very often the types of medication we would use. So bipolar 1 has to be 1 or more manic episodes, can be with or without psychotic features. And often a lot of patients, it usually takes about 12 years on average for a patient to be correctly diagnosed as having bipolar, because a lot of patients initially present as depression, as major depression for a number of years, or often treatment-resistant depression. But they haven't, or perhaps we haven't gone into enough detail on the history to kind of subtly pick out the subtle sort of mixed symptoms or hypomanic symptoms. Bipolar 2 is 1 or more major depressive episodes with at least 1 hypomanic episode. Okay. Used to be said bipolar 1 was far more severe condition, bipolar 2 no, because they're not so manic. The reality is probably bipolar 2 is far more difficult, probably has a worse prognosis, because the bipolar 2 patients are more likely or more prone to having recurrent depressions. They're more likely to have mixed episodes, or what we call rapid cycling, so 4 or more cycles, or 4 more episodes in a year. And then cyclothymic disorder, this is sort of a very cyclical mood. So there are all the features of hypomania are met, all the features of major depression, but the time frame for these cycles is not long enough. And it has to be 2 years or more with at least one, with only 1 month of sort of a stable mood. And then we used to, in the DSM-4, have bipolar NOS, not otherwise specified. They've now brought in a little bit more disorders, and they've called it other specified bipolar and related disorders. That's where you'll see the commonly used ICD-10 code F31.9, which is unspecified. And that's also quite common to clinical practice. So that's where we wouldn't be wrong if we had a patient with major depression and who had some hypomania, but it must be less than 4 days. If it's more than 4 days, they immediately become bipolar 2. Any highs and lows that don't fulfill the criteria that I've specified. Hypomanic episode without major depression is in the ICD-10, that would be single hypomanic episode. Here we could fit it under other specified bipolar. Short duration cyclothymic, so these are the very cyclical, hectic, up and down within a day, quickly over days, and that's also where the differential comes for adult ADHD. Can also sort of, people with ADHD present with a lot of mood swings, or borderline personality disorder. I don't know if you're familiar with the borderline personality. So they also can have a differential of bipolar because their moods are also very cyclical, extremely cyclical. They have rages, they're extremely irritable, they have had multiple suicide attempts. So sometimes it's difficult to tease out what is actually part of a personality disorder, ADHD, and what is bipolar. And so sometimes and often there is a comorbid condition that they exist together. What I've left off here is that also the DSM-5, which is very important, has included mood disturbances triggered by either substances, so substance-induced, or medication. And medication very often, so particularly antidepressants that may have induced suddenly a hypomania or a mania or a mixed state. It doesn't necessarily make the patient bipolar. What does make them bipolar is that if their moods continue after stopping the offending agent, because it could also be a side effect as well. Let me just see. Oops. Maybe I'm. This is. Oops. There we go. Okay, so impact of bipolar, and that's why it's so important that we diagnose early, or as early as possible, and we treat the acute episode, and we continue to maintenance. Depression has a major impairment. Manic, hypomanic episodes can cause significant impairment as well. There's often in our patients the higher rates of unemployment, because obviously for them these episodes can go for months, and rehabilitation can take like 6 months to a year for the person to get better, to come back to work. So they're often on temporary disability, permanent disability, very prone to other psychiatric conditions, so ADHD, borderline, temporal lobe epilepsy, depression in terms of anxiety related, and then obviously the medical side of things, and that's where we'll get onto a little bit in terms of medication, particularly as far as a lot of our meds, the metabolic syndrome. So another big reason why our patients stop their meds is because of weight gain. High cholesterol, particularly the abdominal obesity, cholesterol, triglyceride problems, blood pressure problems. And therefore they're much more prone. Their morbidity is higher than the general population in terms of diabetes, heart attacks, strokes, sudden deaths from arrhythmias. I phoned a cardiologist the other day. I needed to ask if I could start an antidepressant in a patient of mine who had a heart attack a couple of months ago. And the first thing he said to me was, he said, "Doctor, do you know that your medication is dangerous?" So, and I think that's what we forget, and our patients forget. Most of the meds we use is Schedule 5 and above. And another colleague reminded me, because we use these meds all the time, is he said, we're probably one of the only specialities that's actually quite happy to give a 6-month script for a Schedule 5 or more, or higher drug as chronic medication. So we have to be very aware of the risks and benefits of our medication. And again, the impact of treating bipolar is 50% of our patients attempt suicide. and 25%, so it's very high, of completed suicides. When you look at the average percentage in terms of overall suicide rate, it globally is about 7%. So of that 7%, 25% are bipolar. So it's high. Right. So that's just in terms of the comorbidities. So we can see a lot of our patients have a lot of medical comorbidities. And then when we look at the psychiatric comorbidities, personality disorders, ADHD, anxiety disorders, eating disorders, impulse control, substance abuse, and particularly if we look at the comorbidity of bipolar with ADHD, about 21% of patients with bipolar have ADHD, and that sometimes can make the treatment quite difficult. And when we look at ADHD, 20% of those patients have bipolar. So it can get quite complex in terms of sort of teasing out the symptoms and looking at medication, because sometimes...
What do you treat first?
Okay, good point. So priority always goes first organic, medical, second substances, third is your primary psychiatric disorders, so your bipolar, your major depression, schizophrenia, and last comes the personality disorders, the ADHD. So you always, if you've got a patient with bipolar and ADHD, or anxiety and ADHD, depression, ADHD, you first treat the, I don't want to say that's wrong, Renata will shoot me, not that ADHD isn't a primary condition, but in terms of for the particular patient. So you need to first make sure their mood disorder is stable.
Sorry, and you'll treat until it's stable before you start treating the ADHD?
Yeah. A lot of patients get a bit fed up with that because they want to get going on the ADHD medication, but it's far safer because some of the meds for ADHD can actually increase anxiety. They can cause a switch in mood to be hypermanic, manic, rapid cycling. So we have to make sure that they're stable before we add that. Just want to see. Okay, and then just looking at the course of bipolar. So this is also quite a scary thing, and which patients don't, and often us as clinicians don't realize, or we forget, is that with time, the time between each episode shortens. So as the person progresses in their mood disorder in life, they have higher risks, and even being on medication, obviously it's worse if they're off medication, their time between episodes becomes shorter. And also the cycles become shorter. So you can see that it changes from a sort of a typical 1 or 2 episodes a year to be 2 manic episodes, or 1 manic, 1 hypermanic, 1 depressed, to this very quickly cyclical mood. And the average bipolar patient, 10 episodes over a lifetime. So that's quite hectic. And then often the further on you get in terms of life and cycles, the more difficult it becomes to treat, and they often have residual symptoms, and there's often a significant drop in functioning. So it becomes a very, very cyclical disorder. And the problem with bipolar is we often miss it. So we often only much later down the line. I've got a case just briefly to present that's probably, it's possible that for a long time, not that it was missed out of poor management, but just that it didn't present itself, and through life changes, and also as we see with the progression of moods, is that it becomes more cyclical, that the longitudinal picture of bipolar changes. So it depends where you're seeing that person, and that's why it's always good when you do history, is it's important to really try and spend as much time looking at previous episodes going back. But like with all of us, we do forget. And that's the problem where it comes with ADD, ADHD in adults, is we, do we really remember how we were as a kid at school? Do our parents even remember? And then misdiagnosis. So that often happens. So there is a bit of a I suppose with the use of the PMBs, the prescribed minimum benefits, that are we perhaps as clinicians, anybody that presents with sort of a cyclical mood or mood swings becomes a bipolar unspecified. Or often is you may see someone who's extremely anxious and they're talking fast and they're very expressive and they're pressured and they seem like their energy is increased and they're prone to depression, and you think, well, could this be a little bit of hypomania with depression, anxiety? So we've also got to keep checking and re-evaluating our assessments, because I think in terms of misdiagnosis, first of all, both equally as bad, missing bipolar because of the high suicide rates, but also misdiagnosis, because we don't do our patients any favors. They get onto medication that they don't necessarily need to be on, and with all the side effects. And then the other, in terms of which we're seeing more and more, is sort of people applying for life insurance and sort of a lifestyle insurance and that. And, you know, if a person isn't bipolar and they you put down bipolar, I mean, that's a lifetime diagnosis. Okay, and then if we look at the misdiagnosis, so 60% depression initially, so it often presents more as depression, anxiety disorders, schizophrenia, alcohol, substance abuse. That's also quite difficult. I like the term, I can't remember where I read it, called drug polar. So often patients are in their heavy binging and hectic substance using are often misdiagnosed as being bipolar. They often have associated personality disorders. There's very often a strong comorbidity, about 25% of ADHD. And so it's a whole mixture of moods and that, and they're often misdiagnosed in the acute periods and told they're bipolar. And you look, I have a gentleman now, and you look years down the line and there's actually nothing bipolar about his history over years, and he's been on Epilim and he's put on about sodium valproate or valproic acid 30 kilograms over a couple of years. So we really do need to keep reevaluating, and there's no harm in safely tapering meds and observing, obviously with patient consent and understanding. Okay, it's a lot of information. I'm not sure if you can see it all. But this is, if we look at sort of our gold standard, our go-to as far as agents off-label or on-label use, the FDA approved medication for bipolar disorder. So if you look, I'm going to start with mania. You do see the carbamazepine there, okay, the Tegretol. And so just to bear that in mind, and I'll come back to that just now. When you look at bipolar depression and you look at bipolar maintenance, does anybody see carbamazepine? No. And correct me if I'm wrong, but to the best of my knowledge, that it only has registration for for epilepsy, and then for bipolar, for the mania as a mood stabilizer, and for pain. And is it also now for maintenance? Oh, has it? Okay. And so when we look, and particularly, and this is the tricky part, is that if you look at bipolar mania, even maintenance, there's quite a lot of agents for clinicians to use. But when you look at the data and the agents registered for bipolar depression, we're actually at quite a loss as to what has been approved and what has been shown to be effective. And we know that depression is a very risky episode, and it is difficult to treat. Just to sort of, but what's also very important, and this is where I wanted to bring it up, in terms of the bipolar, as far as the DSM-5, the criteria of mixed episodes, so as clinicians, it's important to understand that, but also in terms of this rapid cycling. They don't have rapid cycling here, but in terms of FDA, where carbamazepine can be used is for your typical manias, hypermanias, but also for your mixed episodes. So that's where people often forget that carbamazepine is there and it is approved. Any questions on that? Okay. So we're fortunate that there's a lot of medications. We have the atypical antipsychotics and we have the mood stabilizers. The standard mood stabilizers, what would be fall under that would be your lithium and your valproic acid. And then your anticonvulsants, which would be then, so your non-standard mood stabilizers, which would include lamotrigine, carbamazepine, topiramate, which is Topamax, and gabapentin. Okay, but traditionally, your standard mood stabilizers, the standard mood stabilizers are lithium and valproic acid. Okay. And carbamazepine yet hasn't, that comes as a second line agent. Okay. So this came from an article. We're fortunate on the one hand and we're unfortunate on the other that as clinicians we have guidance. So very importantly that we practice evidence-based medicine. And so there are a number of treatment guidelines. I haven't even included, there's the big one there is the American Psychiatric Association Bipolar Guideline, which I think a lot of clinicians in South Africa tend to follow, and that's our South African, the SASOP, South African Society of Psychiatry guidelines are very similar to the American guidelines. But what you see is that in treatment guidelines, what is evidence-based medicine? Not all the medicines used are, as you'll see, actually FDA approved in terms of the use as far as maintenance or mania, hypermania, or depression. So traditionally, the first-line agents, strong evidence-based, has always been the standard mood stabilizers, lithium, valproic acid, and then your atypical antipsychotics. So that would be your second-generation antipsychotics, olanzapine, quetiapine, aripiprazole, ziprasidone. In the States, they've got lorazepam, which we don't have yet. We're hoping it'll come because it's got a good side effect profile. But when you look at, so you've got the Korean guidelines, you've got the British Association of Pharmacology, the Canadian ones, again, the British guidelines, and a lot of people like the World Federation Society Bipolar Guidelines. And then there's also the Texas Algorithm Guidelines. So there's a number, and there are some subtle differences. But what I just wanted to highlight is that first-line treatment will be typically the lithiums, the sodium valproates, your atypical antipsychotics, used either on its own or in combination treatments. And that's also something that is it's not unique to treatment of bipolar, but it's very typical of psychiatry and perhaps where psychiatrists are accused of polypharmacy, so needing to use 2 or more drugs. But when you look at our disorders and comorbidity, you can see why. And you look at the treatment guidelines, is that if one agent doesn't work, then there's a second step, third step, fourth step, which often involves the addition of agents. And that's very often with the Canadian guidelines, where carbamazepine and a lot of the other guidelines comes in as not first line but second line, either on its own but usually in combination with either lithium or valproic acid or an atypical antipsychotic. The problem with our guidelines is as soon as you get to use of 2 or more agents, there's not a heck of a lot of data in terms of efficacy. I did my master's on prescribing patterns in bipolar at Tara, and I think I had a sort of a sample size of just under 300, if I remember correctly. And we looked at the major classes of medication and anticonvulsants, standard mood stabilizers, etc. I think we had for those patients something like 52 different combinations. So other studies can show up to, and this is just looking at classes, of about 132, 150 combinations. So this is where we do rely on guidelines, but the most evidence of trials and data is really with first line and second line. Okay. So is everybody sort of clear where as clinicians?
What antidepressants do you use? I know with the SSRIs they can precipitate mania. The SNRIs, is bupropion still something that you would use because it precipitates mania?
Yeah, that would actually be one of the safer ones. So, and then if we just look at, I'm going to get onto that now. So mixed mania, psychotic mania, but you can also include rapid cycling. And this is where carbamazepine, in terms of patients presenting with mixed episodes, rapid cycling is a very, very good choice. Okay. And so the guidelines that a lot of people use, the World Federation, carbamazepine is a very strongly recommended, not necessarily first line, it's always the typical ones, but as second line. You'll note that lithium is some include it, some don't. Some feel that lithium isn't effective in terms of the rapid cycling or mixed episodes, that your anti-epileptic or anticonvulsant mood stabilizers are far better. And hence valproate or carbamazepine is often chosen. When we look at depression, you see there's like a whole load. But just pointing out that a lot of the guidelines, not as first line, but some second line and some third or fourth line, will then include carbamazepine as an add-on, as an augmenting agent. When you look at the use of antidepressants, you've got to be very, very careful in your patients, bipolar 1 or 2, because antidepressants can precipitate a mania. A hypermania can cause a mixed episode or rapid cycling. So you never want to use an antidepressant without the cover of a mood stabilizer, an anti-manic. So an anti-manic medication could be lithium, it could be sodium valproate, it could be your atypical antipsychotics, and it can be carbamazepine as well. But when you choose an antidepressant, your safer ones to use are your SSRIs, your selective serotonin reuptake inhibitors, and then your dopamine agents like bupropion. Those are probably the two safest. When you get to your serotonin noradrenergic ones, you can use them and they're very effective, but you've just got to make sure that your patients are covered very, very well with the mood stabilizer. But we use a heck of a lot of bupropion. And it's also great to use with our patients who have comorbid ADHD. Again, it's not approved for that, so we use it off-label, but it is in the guidelines. Yeah. Okay. And then just a note on monitoring. So this is often where we try initially to choose medications for our patients, obviously with good evidence base, but with the least side effects, and are going to be the best tolerated and require the least sort of effort for the patient and the clinician in terms of monitoring. So that's where a lot of clinicians initially would probably go for the atypical antipsychotics, lamotrigine, valproic acid, because they require monitoring, but they're often better tolerated, particularly with valproic acid. You can load quickly with a dose. Lithium and carbamazepine, very, very good agents, but they require a lot more monitoring. Patients need to be aware very carefully of side effects, and they need to be responsible, that they're going to go for their testing. So because both of them Lithium more so. They have sort of narrow therapeutic indexes. So for both of them, but particularly lithium, they can become toxic. Their drug levels can get quite high quickly, so you've got to monitor that. But also with carbamazepine, you've got to be very careful. You've got to do a baseline liver function. You've got to monitor the liver function quite often initially because of the risk of hepatitis, sodium levels, which we often forget, the low white cell count, the neutropenias that you've got to monitor. And it's particularly important in the first 3 months. And then after that, you can do sort of every 6 months. And then also second or in line with the lamotrigine, the risk of the rash, the Stevens-Johnson, so which a lot of people forget to tell their patients about. But nonetheless, all of our meds, as you can see, they do require a lot of monitoring. And then in choosing carbamazepine, so I'll start with the cons first. Okay, so it's not yet got approval in depression. I wasn't sure, but thank you that it now has for maintenance. But in terms of evidence base and some clinical trials and used in treatment guidelines, it's definitely can be a good choice, but it's never or hardly ever used as a first line agent. Also, you need to have regular blood monitoring, and the other thing with carbamazepine is the drug interactions. So it is one that on the P450 system, as far as the enzymes, does tend to eat up other medications. So you've got to be careful, particularly, as you know, with epileptic patients, if they're on other meds, you've got to monitor those levels as well, and the doses of those meds may need to be higher. And then also carbamazepine eats itself up as well, so the levels. So it's really, you know, again, the choice of patient that you use, but that's for any of our meds. You know, there's certain patients that would not be good candidates for carbamazepine. The other important thing, which is becoming sort of more relevant now, and I'm not sure, correct me if I'm not sure if in the package insert in terms of, is it? Yes, is it there? Okay. That's becoming a big thing now. And now that we also have, we've got access to genetic or pharmacogenetics, you know, this is going to be indefensible in court. But it's just important to note, and I don't think as clinicians, people are always aware of that. And then obviously when you're using it for girls of childbearing age, it is contraindicated, but clinically you would manage as risk benefit. But obviously it may not necessarily be the first line, just like valproic acid. I mean, it's actually recommended not to use it at all in girls of childbearing age. But again, just advising on contraception and being careful of the kind of contraception because of their drug interactions. But the pros is that it's very good evidence, and it is FDA approved for the use in mania, mixed episodes. It can also, there's clinical data for rapid cycling. So it may not be an obvious choice when someone sort of first presents with bipolar, but as their disorder becomes more difficult to treat, more cyclical, carbamazepine is an agent that one could look at. Again, very helpful. It may then be the first line of a patient who presents possibly bipolar with temporal lobe or generalized seizures, that you may actually want to use it as first line. Patients who have comorbid pain, neuropathic pain, so again, to try and avoid polypharmacy. A very good reason to also change over is often the weight gain for our patients from our other agents. So they're willing to put up with the drug monitoring and the bloods because It definitely has a better weight gain perspective. And again, it can be used for patients, second line, third line, fourth line, add-on, so augmenting, add-on, and then patients that just don't respond or can't tolerate the other agents. Also quite useful in patients that often have a mood, a personality disorder, particularly patients who have the explosive mood episodes, so that intermittent explosive episodes, that sudden rage and acting out. Patients who have substance abuse, because they're also prone to have, well, they're high risk of having seizures as well from substances. They also have the very cyclical moods. Also quite effective in terms of patients which are left off that we use where there is a medical side of things. So when you're looking at medical organic personalities, or mood disorders because of medical reasons. Again, you've got to be careful using carbamazepine. You may not always use it. You may choose an alternative anticonvulsant like valproic acid because of the drug interactions or the age. But it can be very, very useful in your medical or comorbid medical patients. And I'm so grateful that there's the controlled release. I don't know how long it's been on the market for, years. I remember when I first started and it was just the Tegretol. And you got, I think it was, the 200 milligram tablet, and patients would have to take quarter, like 50 milligrams, and build it up and build it up. From my perspective, the Tegretol CR, it's really easy dosing. Do you know how many people don't know that it's the Divitab? And they're always like, I'm so impressed when I tell them, no, you can actually, it's got that little, it's easy to break. But they say, no, but you can't break it because it's coated. That's where using Tegretol CR, in terms of the use of carbamazepine, we're using it a lot more. Am I allowed to go a little bit off label? In terms of, okay, no. If we look, okay, it's not in the treatment guidelines, but I have been doing some reading, and there are some trials and some studies to show that trileptal, the oxcarbazepine, can be useful, can be effective in management of bipolar, in terms of mania mixed episodes. But again, if prescribing it for non-epileptic patients, it would obviously be off-label, but there are guidelines, it's not in the guidelines, but there is some data there, and I think there will be more data. And the rationale behind it is because it's less need for monitoring, and you don't have to monitor the side effects. It's got less risk of rash. Doesn't drop the white cell count. You just need to monitor the sodium.
You battle to get it approved by the medical aid.
Unbelievably so, yes. Yes, so it's very difficult. So you use it for your epileptic, sort of your bipolar epileptic patients, but for me, it's a medication to use if someone doesn't tolerate Tegretol, and we've tried all the other agents. That it's worth giving it a try, and I've had to, and that's why I've done some reading on it. And in actual fact, there is one guideline that does recommend it, but I can't remember which guideline, but obviously it's like fifth line. And I've had 2 patients do remarkably well with rapid cycling mixed episodes, severe personality disorders. So it's hopefully, that will be another agent in the future that trials can be done for the bipolar patient. Okay, I hope I'm going on forever, sorry.